Good morning, everyone. I'm going to get us started so that we're right on time here. Welcome. I'm Jordan Marmet. I lead the Division of Hospital Medicine and joined the university in 2010. I'm also the medical director for the Newborn and Family Child Care Center, otherwise known as the Newborn Nursery. And it's really in that capacity that I come today to speak about neonatal abstinence syndrome. Why this topic, first of all? Why is this in the hospitalist series? Well, I'm sure you're all aware that there's a national epidemic going on of opioid use and abuse. And, we here at the university have experienced a couple of cases in recent times of some negative outcomes for babies that were discharged from the newborn nursery to addicted moms. And furthermore, we have a brand new policy that's going into effect today, and we'll get to that in a little bit. Let me introduce the speakers who are joining me here today. It's going to be a group of panelists. So Missy Engel is one of the neonatologists in the group who joined in 2015. She's working at Maple Grove Hospital and North Memorial in the NICU area and completed her fellowship here. Janet Kubly is the lead pharmacist for the NICU, has been, or for critical care in general, and has been here since 2000, and was, prior to that, was the clinical director, the clinical pharmacy specialist. And Heather Pajorski is a neonatologist also at Maple Grove and North Memorial, and has been with the Department of Peds and the NICU group since 2012. On to our disclosures. So we have no financial relationships to disclose. We will be discussing a couple medications that are off-label. There's no FDA indication for neonatal treatment for buprenorphine, clonidine, or phenobarbital. And I'll disclose that we have a lot to get through, and so please excuse us for talking quickly. The objectives, we hope that you'll walk out of here today with a better understanding of the prevalence of substance abuse, rates of NAS, Neonatal Abstinence Syndrome. We hope that you'll be able to recognize signs and symptoms of NAS in babies, that you'll be able to list at least 3, why not 3, proven effective pharmacologic treatments and non-pharmacologic treatments for NAS babies. And then lastly, to gain an appreciation for what's new and what kind of opportunities we have here in improving our care for these mom-baby dyads. So starting with the definition of NAS, so coming from Hudak and Tan in the 2012 clinical report, they say that the constellation of clinical findings associated with opioid withdrawal that's found in infants who have chronic in utero exposure to an opioid that can lead to phenotypical and or neurodevelopmental behavioral abnormalities consistent with drug effect. And the signs and symptoms worsen as drug levels decrease. So let me start with the scope of the problem, casting a wide lens, looking across the U.S., hot off the presses. So from a report from Annals of Internal Medicine earlier this month, there's a cross-sectional self-report around the U.S. 38% of adults, or I should say people over age 12 who responded to this survey, 38% said that they had used a prescription opioid in the past year. About 5% said that they had misused them, and almost 1% said that they have an opioid use disorder. So it's not a small problem. The most common reason that they self-reported using medication was for physical pain. And then looking at those who reported, it was women more than men, and then there were socioeconomic disparities. So those who had less than a high school degree, those who didn't complete college, those with lower family income, uninsured, unemployed, all had higher rates of substance abuse reported. With opioid use, we need to talk about deaths related to substances. And so this on the y-axis, number of deaths, just to point out the sheer slope of this line. This is opioid use up to 2010 has really outpaced the other kinds of substances that people are using leading to death. Heroin is listed out here. Yes, it's an opioid, but just to show you that it's not really a heroin epidemic that's going on, figuring into this opioid crisis. Now looking at men and women, and this graph goes through 2015, deaths per 100,000. I just want to point out, if we look at 2010 and we look at the slopes of these lines now through 2015, we see that any opioid is skyrocketing. And so that is, heroin is contributing to part of this rise, 2010 to 2015, but other synthetics like fentanyl are huge players. So now focusing on pregnant women, they're not immune. And if we look at here, the overall line is, these are frequency per 1,000 deliveries. It's going up. I was surprised to see that the number in those under 20 is not as high as it is in the other age brackets. But again, pretty remarkable slopes. Now talking about the babies, because with opioid use in pregnant moms comes opioid dependence, opioid withdrawals in babies. So now NAS per 1,000 hospital deliveries across the U.S., we have reports through 2012 is about the most recent data that's been released, and it's just staggering. If we look at 2000 to 2009, numbers of NAS tripled in that time frame, and then from 2009 to 2012, it doubled again. And so we're looking at a six-fold increase over the past about decade of time. And so this is why there's been so much attention drawn to this issue. So different studies will cite different numbers. This is another slide coming from CDC. But most importantly, why does this, what's the kind of health impact on the system? Well, if we think of a vaginal delivery of a baby and mom being in hospital maybe an average of 2 days, and a C-section an average of 3 days, we're talking about a 23-day stay on average across the U.S. for these babies, nearly $100,000 bill being racked up, and cost to the system estimated at $1.5 billion, the national system. So not peanuts, shall we say. Some important NAS facts. So we're talking about maternal use of the common pain relievers, morphine, maybe codeine in there, oxycodone and hydrocodone, important ingredients in Vicodin and Percocet, hydromorphone or Dilaudid, and fentanyl. There's illicit substances. We don't have much opium here in the U.S., but heroin is a big player. And then those who are in a controlled prescription monitoring program who are getting methadone or buprenorphine, otherwise known as Suboxone. There are other meds that are implicated in NAS, and oftentimes it's the polypharmacy in moms where these are becoming a bigger issue when there's multiple substances being used. But moms who use amphetamines, barbiturates, even nicotine alone, as well as SSRIs, really can exacerbate those NAS symptoms in babies, the withdrawal symptoms. Now let's focus in on Minnesota in general. If we compare ourselves to the other states out there, we're actually on the lower side. So we're somewhere between, if we compare ourselves to these states that are in purple, we're somewhere between 2 to 3 times less likely to have opioid abuse. And this is really looking at prescribing rates, but one would extrapolate our opioid abuse is concomitantly less. And now focusing, this is Minnesota deaths, number of deaths on the y-axis. And I just want you to see the slope of the line. These deaths that are opioid related really are going up. And now focusing very locally, Minneapolis and St. Paul. What can we say? So this data from MDH is talking about cause of death. These are absolute numbers, 2006 to 2016. And we can look at, yes, deaths are increasing due to all these substances. Methamphetamine, well, actually going down for cocaine. But opioids, 153 in 2016, is just outpacing its competitors, if you will. This is Hennepin County and Ramsey County below. So it's a scary epidemic that's right here. It's in our backyard and our front yard. Which moms should get screened? This is a busy slide, but this is part of the new policy that's getting rolled out today, and so I do want to spend a couple minutes talking through it. So which moms should get screened? Obviously those that are in a prescription monitoring program, that goes without saying, but any mom who's tested positive during pregnancy at any point should be screened after delivery or during her hospitalization, as should the baby. Any mom who declines prenatal testing, current or prior unprescribed drug use, that goes without saying. Altered mental status. So if our staff is noticing that the mother is acting strangely, is showing any symptoms of withdrawal. If there are physical signs of drug use, so that might be things like track marks on arms, that might be really awful tooth decay, sores all over the skin. If there are complications of drug use, so a history of a CVA or an MI that's really not explained by their medical history, hypertension is a little tougher to tease out in pregnant and delivering moms, but if it's just not explained, a previous infant with neonatal abstinence or even fetal alcohol syndrome. If there's active alcohol, and this is a change, or tobacco use during pregnancy, these moms should get screened when they're here in the peripartum areas. Unexplained Hep B, C, or HIV. This is something that that Iowa has put into place and that we've decided to include. So this is within the past 3 years. Is there a new infection? Poor prenatal care, as defined as prenatal care initiated after 16 weeks gestation, or less than 4 or less visits during their pregnancy. Poor weight gain during pregnancy. And present or past OB events. So this is pretty broad. If there's an unexplained abruption, if there's a stillbirth, a fetal demise, even a precipitous delivery or a birth out of hospital, and again, this is present or past, then we should be screening these moms. Also, if there's ED or care visits that have triggered questions where people have gone to look at the prescription monitoring programs. And then a few others, since that wasn't enough, a few other social risks that'll trigger it if they're reporting domestic violence via their current partner, if there's substance use even in that partner, we should be screening these moms. If there's a history of incarceration and any past CPS involvement for abuse or neglect. Lastly, if there's screenings that are specifically requested by the county or by the tribal authority. So this is a wide net, and the idea is that we should be casting a wider net. We should be screening more moms than we currently are. I just saw some statistics looking at how many tests were run on babies in our institution over the last year and a half, and it was about 200 in the last year and a half. By casting a wider net, we are going to be screening more people. How are moms screened? A urine. Yes, a urine looks like this. That's the recommended and only screen that we're going to be doing. And the timing, it needs to be somewhere for this mom between the time she's getting admitted up to 8 hours postpartum, because urine doesn't hold on to the drugs as long as other modalities. Onto the baby. So which babies should be getting screened? As we talked about, all those risk factors in mom, known or suspected use, and then baby factors. So an unexplained premature delivery, unexplained birth weight or OFC that's less than 10th percentile, clinical signs and symptoms of withdrawal, that's an obvious one. Also unexplained conditions, so seizure, stroke, some congenital malformations of the abdominal wall or GI-GU areas. And how are babies screened? No, I didn't show a picture of meconium for you, so you can eat your breakfast, don't worry. But urine, meconium, umbilical cord I add on here. That's a newer one that we're going to be doing. It's still in research phase. So this is a snippet of the umbilical cord that's sent to the lab. As we study it, if it proves to be a very effective tool at monitoring substance exposure, then we are going to make it more prime time in our system. And physical symptoms. So when we get positives, what do? First piece is communication. So if a test turns positive, providers are notified by the lab or by the nursing staff, who's going to be notified along the way. So this is baby providers, maternal providers, social work is going to be involved. And then there is mandatory CPS notification for any positive in mom or baby in the newborn period of time. And a newer Minnesota Department of Health notification is required as well, because this is something that goes into their tracking of data, that they want this reported to them with the birth certificate reports that are going out there. And what kind of monitoring do we do for these babies? Well, we'll talk about Finnegan scoring in a little bit, but these babies are kept in house anywhere from 72 hours up to 7 days, which is new, and the thought is that moms who are on longer acting medications like methadone, babies really need to be monitored for a longer period of time to make sure they're not withdrawing. So with that, I'll pass the baton.
Right. So the physiology of opioid withdrawal would be that an opioid receptor agonist binds mu opioid receptors, resulting in decreased noradrenaline release. You get tolerance with chronic exposure. Noradrenaline then increases towards normal levels. And an abrupt discontinuation of the opioid results in excessive release of noradrenaline, producing the autonomic, behavioral, and GI symptoms characteristics of NAS. Those symptoms can include irritability, high-pitched cry, tremors, hypertonia, hyperreflexia, sleep problems. It can even lead to seizures. There can be sweating, sneezing, mottling of the skin, hyperthermia, some nasal congestion, as well as symptoms of loose stools, poor PO, poor weight gain, and dysrhythmic sucking, swallowing, and you can see tachypnea. And so then these symptoms can be monitored using the NAS tools that I'll talk about in a little bit. There can be a variation in the onset and duration of withdrawal depending on what substance the mother was taking. So for methadone, which is a long-acting medication, you can see that symptoms can begin 42 to 72 hours after birth, but a baby can withdraw as late as 3 to 4 weeks of age for some babies. And then the duration of symptoms can be weeks, and methadone therapy often is needed for these babies to help control their symptoms. For the shorter acting, such as morphine, oxycodone, hydrocodone, symptoms generally present within 24 to 48 hours and last about a week, with short-term morphine therapy often being needed. For heroin exposure, you can see symptoms within 24 hours, and those last for days, and a short-term morphine therapy can sometimes be needed. Preterm infants, interestingly, often show a lower risk of NAS because a shorter length of exposure, lower fat stores of the drug, and just the developmental immaturity that they have. And also some of these NAS scoring tools that we have just aren't as effective or useful in preterm infants. There are multiple different scoring tools. I'll talk a little bit about the two most commonly used ones, but it's important that an institution have a way of looking systematically, thoroughly, and hopefully objectively, depending on the staff's training in using that tool to document the course as well as the need for pharmacologic therapy. Generally, these scoring guidelines would suggest initiating scoring every 3 to 4 hours, and that shouldn't be something that the baby's woken up for to say, oh, okay, now it's time for me to score this baby. It's really meant to be over that entire time period, what the baby's been acting like. And then when babies do have higher scores or initiate a pharmacologic therapy, then increasing that to every 1 to 2 hours. So the most widely used assessment tools are the Finnegan and the Lipsitz, but there are others that are out there, and even there's a recent article from June from Yale that was using kind of their own homegrown scoring system where they were just looking at the functionality of the baby. So the important thing is really making sure that that whatever you're doing, that the staff feels really comfortable with it, and that between evaluators that there isn't much discrepancy there. So the Lipsitz looks at 11 variables, and they score 0 to 3, and they start pharmacotherapy at about greater than 4. And then the most widely used tool, and the one that was recommended by the AAP in 2012, is the modified Finnegan Neonatal Abstinence Scoring Tool. It looks at 21 items, and symptoms are weighted based on the severity of the symptom. You can get a total of 0 to 44, with normal babies ranging between 0 and 7. So many institutions then will start pharmacologic therapy for repeated scores greater than or equal to 8. However, some institutions choose a different number or use an average of numbers. There are some non-pharmacologic therapies that can be helpful for alleviating symptoms, and these therapies can be taught to parents and caretakers to possibly help prevent the need for pharmacologic treatment in infants, especially with mild symptoms, using a low stimulation environment, dimmed lights, clustering their cares, doing some infant massage. Hyperthermia can be one of the symptoms of NAS, and so using a cotton blanket instead of the fleecy big swaddle sacks can be helpful. C positioning and vertical rocking has been advocated, and then using some of our occupational and speech therapists, as well as optimizing their feedings. Part of that non-pharmacologic treatment is really providing non-judgmental, family-centered care that can start with prenatal counseling for mom to know what to expect during the hospitalization, and then attempting to keep the mother-infant dyad together so that mom can really act as therapy for baby, and use that opportunity while they're in the hospital to encourage appropriate parenting skills, help the mother learn infant cues and how to respond to them, and then also to promote breastfeeding if that's appropriate for that mother. Occupational therapy can be helpful in evaluating and treating abnormal muscle tone and irritability and self-regulatory skills. They can help nursing staff in providing an appropriate environment for the infant, and also provide instruction and a supportive environment for the parents. One of our occupational therapy therapists at North Memorial put together a video for training for our nursing staff and parents about some of the techniques that can be helpful for calming. Oops. Here we go.
Here with Karen from Occupational Therapy, who is going to demonstrate to us the C position for bundling and for holding the baby and sleeping.
Mm-hmm. So this C position is the most comfortable and regulating position you can put your baby in. Now we are using a doll, so the baby does not move quite as well as your baby will move and bend his joints. The C position is thus. We want his hips, his knees, and his feet all bent about halfway, both legs. His arms are going to be bent at the elbow, at the shoulder, and at the hand, at the fingers, so that he's almost looking like he's going to suck on his fingers. So then I'm going to start to swaddle him. I'm going to bring the blanket, and we're going to try to swaddle him into that position. We're going to wrap his hands in that position, tuck him under, again get our feet in that bent position, and we're going to swaddle, bring the bottom up. Sorry, baby. And then we're going to bring the other side around with his hands bent up again to keep him nicely, firmly tucked in. And it's a fairly firm pressure so that he feels secure. Then when I pick him up, we're going to try and keep him again in the C position, and his body is in the C position. So you can see that it should look kind of like a curvature and being bent. And his head would be slightly bent as you keep him. Then you can easily do the vertical rocking with him up and down. And it's a slow rocking. You don't want fast. Any fast movement with these babies, it's a very slow rocking. This position, then, you could easily then put him back in his crib on his back. Again, your baby's feet will come down more and be tucked in, but this is a demonstration down that it's stiff. And that is C position.
So optimizing feedings is also important, and breast milk in these babies is still best as long as there isn't illegal substances being used or a positive HIV status. So encouraging moms to breastfeed is important. There is a small amount of morphine that can be passed through breast milk. It is poorly bioavailable. Then methadone levels generally do not exceed more than 5% of the maternal dose. and so infant serum concentrations are pretty low. That being said, it's still important to encourage that moms, when they choose to stop breastfeeding, that it's not an abrupt discontinuation of breastfeeding. I have seen babies be admitted within the first month of age when mom abruptly stopped nursing. So that's something to counsel moms about. And then one thing I've seen many moms and staff members complain about is kind of this gas pain. So sometimes at least at Maple Grove, our speech therapists will help us with finding an appropriate bottle if they are bottle feeding, to try to prevent much air getting into the stomach, trying to do frequent burping and minimizing crying. So in summary, it's for non-pharmacologic treatments, it's important to consider them as important as the medications, and to consider the mother as part of that care and treatment team. And then also, just as a side note, supporting our nursing staff who are taking care of these babies, because it can be very difficult. We've at Maple Grove had some babies where they've had a longer length of stay, and we've instituted having a weekly debriefing for the staff in order to be able to discuss some of the topics and things that are coming up with that baby's care in a way that can be constructive.
All right, so we've correctly identified a baby with NAS, and we've gone through our assessment and implemented all the non-pharmacologic measures that we can, and the baby is still experiencing significant symptoms. So what's next? Well, we get to the medications. So there are a couple of indications for medication therapy with NAS. Moderate to severe symptoms not relieved by supportive measures, and the prevention of severe complications of NAS, such as seizures or failure to thrive. What is not an indication for medications is to get symptoms of. So once we start medications, it can be tempting to kind of continuing to treat until your scores are super, super low and being unwilling to wean. But realize that once we start a treatment, they are still going to have symptoms, but they just need to be reasonable symptoms that allow the baby to continue to grow and thrive. So once we do start medications, we know it's going to have a couple of effects. It's going to decrease the acute symptoms of NAS, but it is also going to prolong the hospitalization. It is also going to impact infant-maternal bonding. And really the long-term risks and benefits on neurobehavioral outcomes is unknown. So we do this to help the baby's symptoms and to help them continue to grow and thrive, but we really don't have a lot of information on what the long-term outcomes are. As Heather kind of talked about, institutions have varying criteria for when they might start medication therapy. It's usually based on their scoring system, whatever scoring system you're using. There is not one best evidence-based protocol for treating NAS. The important thing is just to have a protocol for the assessment and treatment so that you're being consistent in how you approach these babies. So our medication options are several. We have the opioids and the non-opioids. And most institutions are going to use one of the opioids as kind of their workhorse agent, and then use the non-opioids as adjunct medications if symptoms are not controlled. And that is what we do here. I would say morphine is kind of our workhorse and our initial start of treatment for babies. So we're going to start around 0.05 milligrams per kilo per dose. Just keep in mind that you may need to round the doses a little bit. We have the commercial solution here, which is 2 milligrams per mil. So we can't measure super minute dose titrations. Some institutions may have a compounded dilute solution and may be able to measure doses a little bit more with finer increments. So you just need to know what your institution has and follow their guidelines. Then you're going to dose titrate as needed to get your symptoms under control. And once they're controlled, you can taper by 10 to 20% every 1 to 3 days. The rationale or why we might choose morphine over methadone or another agent is that it's shorter acting, so it is a little easier to titrate. And then also your taper is going to be shorter for patients that really don't have a significant need for opioids. So there are some advantages to morphine. If morphine isn't enough, we would generally progress to methadone if we've done several dose escalations with morphine and we're not getting symptoms under control. Some institutions would use methadone as their primary agent, so there's not one right way to do it. Initial dose is again going to be around 0.05 milligrams per kilo, but your frequency is going to be a little longer just because it's a longer acting agent. While you're titrating methadone, you may need to have a rescue morphine dose available because you're not going to be able to titrate the methadone up as quickly as you would the morphine. So while you're waiting for that methadone to get to steady state, the patient may still be having significant symptoms and you may need to be able to give a rescue med to treat those. As far as the max dose or kind of the recommended upper limit, the AAP guidelines just say to titrate to effect. But I would note that it's unusual for NAS patients to need doses greater than about 0.2 milligrams per kilo per dose. There are definitely other types of patients that need doses higher than that, so this isn't saying that that's a max dose for everybody, but just realize that if you're getting to those upper doses, that you may need to consider adding adjunctive agents rather than just continuing to escalate the methadone. So again, you're going to get symptoms control and then start tapering by about 10 to 20% every couple of days. You will probably need to, not taper every single day with methadone just because it's going to take longer to see the effect of that dose decrease. So you're going to want to give it a few days on your new dose before you start titrating down. Why we might choose methadone over morphine. One is that it is longer acting. So our symptom control is going to be a little more steady on methadone rather than on morphine. So less of the ups and downs in the medication levels. As Heather mentioned, if mom was on methadone, especially if she was on it throughout the whole pregnancy, we're probably more likely to need methadone rather than one of the shorter acting agents. And then it is possible to discharge patients who are still tapering methadone, where we would not do that with morphine. But keep in mind that it's kind of you need the right candidate of patient in order to feel comfortable safely discharging them. And the right candidate is going to be a patient who is going home to a stable social situation where mom has lots of good support, and also where the primary care provider or the pediatrician is comfortable continuing that taper. So they need to be ready to handle that in the community. So it's kind of a partnership to figure out whether it's appropriate to discharge a baby who's still tapering, but just realize that that is possible. So one of the newer options that we have for treating babies with NAS would be buprenorphine. Our initial dose is around 5 mics per kilo every 8 hours. But it's important to note that you need to compound an oral solution in order to be able to administer this. And then with buprenorphine, because you're going to titrate about every 24 hours, you may also need a rescue dose available for the patient. So you're going to increase by 20 to 25% if symptoms aren't controlled. And you can also shorten the interval to every 6 hours. There is a recommended upper limit for buprenorphine as well of 60 mics per kilo per day. And then you're going to decrease every 24 hours or so by about 10% when you're ready to taper. So the rationale for using buprenorphine is that there's newer information that looks pretty promising, but the data is fairly limited at this point. But there was just a recent study in the New England Journal that demonstrated lower medication exposure and shorter length of stay compared to morphine. However, one of those drawbacks, like I said, is that your institution needs to be able to compound an oral solution. And the recipe that I found did include 30% alcohol. So that's, one drawback of having to use that is that you're exposing them to something else as well. So some of our adjunctive options would be clonidine. So that's an alpha-2 adrenergic agonist. So it's really going to work to decrease those autonomic symptoms, such as like the sweating and tachycardia. Initial dose is 0.5 to 1 mic per kilo. You can go up to every 3 hours. But again, with clonidine, you're going to have to be able to compound an oral solution. The commercial oral solution is pretty concentrated, so you wouldn't be able to measure baby doses this small with the commercial solution. So here we make a 5 mic per mil oral solution to use for infants. Again, tapering you're going to lengthen your frequency and decrease your dose in a stepwise fashion. But keep in mind that if you're tapering the opioid at the same time as you're tapering the clonidine, clonidine has been associated with some rebound symptoms as the dose is decreasing. So just be aware of that, that as you're decreasing that dose, are your symptoms coming from the opioid taper or from the clonidine taper? And you may have to go back up. So clonidine can be really helpful in patients with significant withdrawal, despite several dose increases of their opioid. So phenobarbital, we use that less often here as adjunct therapy, but it can still be helpful. And some institutions might use that as their first, second line agent. So phenobarb is also available. It's a little bit harder to titrate. In fact, I almost wouldn't titrate it very much. I kind of just start the standard dose, and just to help out as much as it can. It has a very long half-life in neonates, and the liquid preparation also contains high amounts of alcohol. So it works via GABA, which is the primary inhibitory neurotransmitter in the CNS. So you can give a loading dose. You don't have to. The range would be anywhere from 15 to 20 milligrams per kilo as a loading dose. And again, with that long half-life, it takes a while to get to steady state. So that's maybe why you would want to try a loading dose. And then the maintenance dose is around 5 milligrams per kilo per day. When you're ready to taper, you can kind of allow the patient to self-taper. They can just sort of outgrow. Again, with that long half-life, it sticks around for quite a while. Or you can also consider just a weekly dose decrease once the patient is stable off their opioid therapy. So once we've started medication, we need to make sure we have a good mechanism in place for assessing the efficacy and also determining how to titrate it, whether we're titrating up or ready to taper down. So with morphine, we're going to have a fairly rapid response and be able to titrate up quickly. With methadone, the peak response takes 3 to 5 days. So if you start your methadone dose and your scores are going down in the 2 to 4 range in 48 hours, you've probably overshot a little bit, and you need to wean that quickly so that you don't end up with respiratory depression. And it's just important to note that babies who've been struggling with withdrawal may be very restful when we first started medication. That does not mean they should have respiratory depression or that they shouldn't be waking up to eat. They should still be being a normal baby, but they just might, they're exhausted from days of symptoms. So they might take a lot of naps in the beginning. And it's, as we know in pediatrics, when we're caring for a baby, we're not just taking care of the patient, but we're caring for their whole family. And in NAS in particular, we need to be really mindful of supporting their mothers in becoming that best caregiver that they can be for their baby. So with that, I will turn it over to Missy.
Okay, so I'm going to talk about trauma-informed care in the NICU and in general. So trauma, as described by Substance Abuse and Mental Health Services Administration, is defined as the 3 E's, that there's an event that occurred with an individual that created an experience that caused a long-term effect. The study that I looked at was very, very old. It was from 1984. But at that time, the amount of women that were surveyed, 25% had been raped at that time, and 33% had been sexually assaulted in childhood. Now, this has nothing to do with NAS or anything like that, but it was just a staggering number that I thought back in the 80s was quite interesting. And also, relatively recently, in the 1970s, they started talking about battered women's syndrome and battered child syndrome in the health and legal domains. So even though that was almost, 40, 50 years ago, it's still relatively new within our system. So trauma in the NICU, parents experience lots of different ways to be stressed. And so not only is their baby hospitalized, but they're in an intensive care unit. Usually, with any of our parents, with NAS or without, they can also have relationship tensions with a significant other, financial strains. They know that this stay is going to cost a lot just from the intensive care. They can have other mental or physical diagnoses that could be hindering them or making them extra stressed for being in the hospital for long periods of time. Also, the medical setting just having, being in a gown after delivery, being touched by nurses for other physical exams after having a baby, being in vulnerable physical positions, just a lack of privacy. We see this a lot with all of our moms about how uncomfortable they can be, especially, we don't wear white coats in the NICU, for germ reasons, but seeing the white coats, being in uniforms, that can be a major stressor for some moms. And also the power hierarchy. You have your attending, your nurse practitioners, your residents, everyone, and they always feel like they're on the bottom and that they aren't a very important part of their baby's healthcare team. But really they are, and we want to support them and be including them. And also from the baby side, there's significant body of research showing that the NICU can be a significant stressor for the baby as well, being separated from their parents in some instances when we don't have private rooms, and just all the procedures that we put them through. So for moms to get help compared to men, usually they have other substance abuse treatment barriers, so lack of childcare for their other children or the child that they currently have, fear of losing their children to the welfare system because they're admitting a problem, and they usually have less money than male counterparts. But new recovery programs are being integrated that support women in these issues and help with childcare and help them overcome their abuse issues. So we're trying to make it easier for these women to get off their narcotics if needed. So trauma-informed care came about because of the ACE study, so adverse childhood experiences, and other studies that showed that childhood trauma has a connection between the adult decision-making and emotional and physical connection to others. The more trauma you experience as a child, the higher risk you have of having some dysfunctional connections as an adult. So this was started in mental health, addiction, and child psychology realms, and it has now moved into the hospital and clinic settings for us. And it's a way for us to offer a better way to have families cope with their substance abuse and other trauma as well, but we're going to focus just on substance abuse for this talk. So they talk about with the trauma-informed care about how always being exposed to trauma, you are either in a hyper-arousal state or a hypo-arousal state. And so you can see in these moms, if you're in the hospital setting or in the NICU setting, that they might show symptoms that we think are odd. They're sleeping a lot or not sleeping a lot. They're eating a lot. They're not eating a lot. They're showing a lot of shame or guilt for their baby being in the NICU because they know it's from the medicine that they took. Depression, anxiety, anger, all those things, these are the symptoms that we should be looking at so that we can help them become a more informed part of their healthcare team and have them feel engaged with their baby's care. So how do we get started? So the trauma-informed care is based on the 4 R's. Realizing the prevalence of the trauma or substance abuse in this case, recognizing how the substance abuse affects all the individuals involved. It may affect one woman different than another. How does it affect the nursing staff? How does the idea of opioid prevalence, abuse prevalence affect you as a physician? And responding by putting this knowledge into practice and trying to decrease re-traumatization for these patients and for their families. So here is a whole bunch of ways on how to do the 4 R's. It's a very busy slide, but you can look at it later if you need to. Basically realizing that the opioid crisis is a big problem in our front yard and backyard, as Jordan had mentioned. Recognizing that it might affect every person differently in the NICU and that we have to support our staff as accordingly. Responding to these families, realizing that they are most likely in a hyperarousal state and that we need to reinforce to them that this is okay, we can treat their baby and they can be a part of the treatment team, and resist re-traumatization. Help these moms become more confident in their care. So as a fellow, I was part of a quality improvement team that worked on starting an NaS protocol at St. Paul Children's. We had an interesting group of mothers over there because there is a couple community hospitals that work with pregnant moms on methadone. So we have a few more than average babies come through St. Paul, and we thought we needed to standardize the care at St. Paul Children's. So from when I did my chart review way back when, most of these moms were exclusively prescribed their opioids, either from the methadone clinic or from their OB for certain pains. We only had a couple actual heroin mothers. I'm sure that's maybe changing. I haven't been there in a couple of years to look at charts. But St. Paul Children's is set up with individual rooms so the parents can have the quiet and take care of their babies in a quiet room by themselves if that's allowed. We use the non-pharmacologic interventions that Heather had mentioned, and breastfeeding is encouraged if allowed by what medications the mother was taking. Our protocol is different because we used methadone as a first agent, and we did that knowing that we could most likely discharge these babies on a daily dosing of methadone. We made sure that the pediatricians were okay following these infants as an outpatient with a daily dosing of methadone. And more than likely, these parents decided to follow up with the St. Paul Children's Clinic. So then therefore at the same visit, the pain and palliative care team from St. Paul Children's could, or Children's in general, could also monitor the methadone as well. When these babies were sent home on their daily dosing, we had home health care follow these infants up to 3 times a week to make sure the parents were supported at home. And if they had any questions or concerns about routine baby care or about their methadone weaning, they constantly had someone to talk to. And the protocol went actually very well. We started with methadone of 0.05 to 0.1 milligrams per kilo per dose every 6 hours, and you can see how the progression went. And once we got down to a daily dose, and we knew the pediatrician they were going to follow up with was okay if it wasn't the children's clinic, we were able to discharge as long as the family felt confident in the baby's care. So our results, we decreased the length of stay from 13.7 on average down to 10.9. That was a 20% reduction in length of stay for the babies at St. Paul. And this equaled out to about $11,200 in savings for each NAS admission. And it was probably more than that because this was just the NICU bed space. We didn't consider the MD charges, the pharmacy charges, any of those additional things. But this is what I could extrapolate out from the powers that be in children's. So we had no increase in readmission rates when we were able to set this protocol into place and have the babies go home on the methadone. And interestingly, when I read all the home healthcare nurses' notes, the parents weren't interested in taking the methadone or using it for themselves. It was actually quite the opposite. They were worried they were going to spill it. They were worried their babies were going to go through withdrawal, the normal shaking or regular irritability in a baby. They thought that was withdrawal, and they were actually more concerned for that than the opposite. So it actually worked very well. So ways I have seen trauma-informed care help mothers in the NICU. This just happened this winter. I had a baby at North Memorial, and mom was a heroin addict. She got into a program. She turned her life around. She became pregnant. And she said to one of my nurses overnight, said, I should have just stuck with heroin. My baby wouldn't have gone through this withdrawal. And I'm so proud of my nurse because she said, no, your baby still could have had withdrawal, but you did the correct thing. You turned your life around. Yes, your baby has withdrawal, but if you stuck with heroin, you wouldn't have your baby at all, you know, and so reframed this situation into a positive for the mother. And that mother's personality and outlook on this admission really changed after that, and she became empowered. In St. Paul, I had a mother who had a pregnancy after being sexually assaulted. And so when we were an all-female team, she felt a little more empowered to talk when the hierarchy wasn't there of having a male attending male residents. And so it just so happened that we all happened to be female at that time. And you could see the difference in her personality when we walked into the room rather than the week prior. And I've also seen mothers start weaning their methadone after being in the NICU. They didn't realize that the methadone could affect their babies this way. And they realized they needed a lifestyle change after seeing what their baby has gone through when they want to have other children. So the benefits of standardizing care show shorter treatment courses and hospital stays. In Ohio, they had a perinatal collaborative and a multi-center cohort showing that they could shorten their length of treatment very well. Also, there's been a Vermont-Oxford Network NaS collaborative, which was back during my fellowship and which Heather also went to, that showed participating hospitals shorten their length of stay, shorten their length of treatment significantly. And so when we work together as a team, we can improve the healthcare for these babies. So as Jordan had mentioned, we're rolling out a new protocol today at Masonic. There's a work group that's meeting and working on different scenarios that we encounter with moms and babies. We would like to make sure we do appropriate screening for these moms and babies, and the new screening does go live today, as we mentioned. We'd like to improve the education for moms prenatally before they come into the hospital, and also postnatally so they know what to expect if they have to be admitted for further pharmacological treatment. Working on decreasing the stigma and bias from our care, using the trauma-informed care to help minimize the stress for these moms and babies and families. And balancing our length of stay. You know, we don't want to keep babies here too long, but we don't want to get them out too early so they have to be readmitted. And also we are working on the umbilical cord screening of the actual tissue to see if that would be a better way to diagnose these babies. All right, any questions? Time for questions.
So we did want to reserve some time for Q&A here at the end, and so we'll pass the mic back and forth. Yes, Mark?
Nice presentation. Thank you for that talk. I ran our step-down nursery in 1984, so as you alluded to, very old experience. But back then it was all about heroin. And, you know, a lot of these babies would declare in the nursery. We used to argue about whether we should use paregoric. Thank God that's no longer on the pharmacopoeia. But my comment is that a lot of the time the diagnosis in the baby was the harbinger of a problem in the mom that had gone undetected. Mm-hmm. I appreciate from your comments that most of these women that you're working with are in treatment. Mm-hmm. And you already know that they are on methadone programs. So I guess my question is the experience very different from the early 80s in that you're not really picking up babies coming in whom abuse has not been suspected. It feels like a different mm-hmm. experience based on your comments about your program. I wonder if you could comment further.
I think it depends on which hospital you are working in. St. Paul, we had a lot of prescribed methadone, opioids, Percocet. When we are at North Memorial, sometimes we get some surprises. And Maple Grove, we seem to know these moms when they come in as well. I think we're doing a better job looking at mom's history and asking the right questions when they come in. So we kind of know, but we still do get some surprises. But it seems like most of the moms are on a medication rather than street drugs at this time in our neck of the woods.
I think that's probably true here too, that we most of the time know. And I think there's usually if there's a concern, there's kind of some telltale signs on the prenatal side. So the radar might be up for watching for issues if there was limited prenatal care or other things. So I would say we still do get surprises, and sometimes with the other substances, we've had a few surprises in the last couple of years in the NICU with a known alcohol use disorder. So,
by and large, this is a problem we've created as physicians.
If you look at Jordan's graph showing how much of it is prescription medications, those are going to be longer acting than the heroin. So hopefully we're catching those babies before they end up being discharged. But for a normal newborn in newborn nursery, they're here for 2 days. So I don't know if we know if we catch all of the babies with that. I don't know, Jordan, you could probably speak to that a little more.
I just add that with the screening, with casting a much wider net than we were previously, we'll hopefully be catching those situations. So screening smoking moms, screening THC abusing moms, we're hopefully going to be screening those babies, identifying those babies who are at risk and watching them very closely, doing those Finnegan scores and seeing, are they withdrawing? Yes, then they need to be moved into a therapeutic arm.
Hi, I have a question. I really enjoyed it, but I'm over at Hennepin, and I had a question and a comment. One, gabapentin is a drug of abuse that we see not infrequently now, and these babies have severe hypertonia. I mean, even worse than normal. So I noticed that wasn't on your list, but we see that over there. And then what have you decided for, so we always talk about this, how long is a time for not using? Is it okay that you're clean for 2 weeks, 4 weeks, 6 weeks, 2 months? We go over and over this, and we don't really have a time we're in agreement with. But anyways, I wondered if you had any consensus on that.
Do you mean with respect to like how long should they not be using polysubstances for breastfeeding or for? Yes, to use mom's. Okay. There was an article from a couple years ago that suggested it needed to be like at least 90 days. But I don't know that we have a set time period. So we really take it kind of case by case, and we debate that as well. So I think you look at a lot of factors with the mom as far as their motivation for staying clean. Do they have good social support? Are they in a program? And because I think we really want to breastfeed whenever we can, but you kind of just have to take all the factors at play in that case and then make the best decision you can.
We have at North Memorial and Maple Grove start to introduce a policy through the NICU that if they are THC positive, we wait 2 weeks on average before we reintroduce the breast milk if the baby's going to be that long. If it's methadone or a prescribed opioid that we know a physician has given the mom, we let them use their breast milk. But when we have polysubstance use, we have just said no breast milk from these moms. We have run into problems with like the 25-weekers that are there forever, and, mom has shown us that we're clean. We don't know what to do with those instances yet. But for the most part, if there's more than a prescribed drug, we say we will not use their breast milk in the unit.
Just had a question about the new screening policy. You had this long list of criteria that would lead to screening. My question is, what is the cost of screening, and could an argument be made just to screen all moms, make it standard of care and routine?
So I didn't mention it, but there are some institutions that have gone to universal screening. Cincinnati Children's is a good example, and it might have to do with their prevalence in their community. And a cost-benefit analysis. At this point, we're looking at a targeted screening rather than a universal screen as being the best for the time being.
So we commonly will see babies under a week of age discharged at 2 days of age come in because they're feeding poorly, they're fussy, there's a lot of symptoms that overlap with sepsis. And my question is, we're not probably screening them adequately for this. Can we do a urine tox screen on a 5-day-old and have it turn positive, or is that too long for that to be useful?
That would be too long. In fact, in the baby, if you don't catch the first void, you might miss some of the medications.
So we're not going to convince the parents to give us, urine samples typically, and so where does that leave us?
I think if you're worried about opioids, then there's some symptoms that are fairly specific to opioids, like really those loose, watery stools and emesis and the tone and the hypertonia. So look, if you're thinking of opioids, you want to look for some of those specific symptoms. Some of the other medications that baby might have symptoms from, like the stimulants, cocaine and amphetamines, those, oftentimes it's not withdrawal from those substances, but actually toxicity. And so that should actually wash out fairly quickly, over a couple days to a week or so. So if the symptoms are going on longer than that 5 to 7 days, then maybe there is something concerning that needs to be assessed a little bit more. But yeah, urine screen at 5 days is maybe if there was methadone exposure, but especially something like heroin, it's gone by that time.
And I would say, if there's question of rule out sepsis, those babies will be admitted. And if there's not, and there's significant social concerns, you still could admit a baby for observation, and we could do modified Finnegan scoring of that child and make a clinical decision on whether or not child would merit treatment.
Last question. Oh, hi, I'm Chris Mattson. I'm just thrilled about this because I was here 30 years ago as a PEDS resident, and this is just so much fun. And I'm back now, if you can believe it, as a addiction medicine fellow. So my experience has been as a Suboxone provider for the last 10 years or so, most recently working with Native Americans in northern Wisconsin. And so we had a lot of these issues. Number one, I'll just say my observation is that of my patient population, which is not scientifically significant, but still I think important, it is really dramatic how much worse the neonatal abstinence syndrome is when they have tobacco and marijuana. So almost all of my patients use tobacco and marijuana, and everybody blamed the Suboxone or the Subutex that they were on. Well, okay, sure enough, they were on Subutex. It causes neonatal abstinence syndrome. But so does the tobacco, and so does the marijuana and any other substance or even prescription drug that they might be taking. And I think sometimes we get too carried away with looking at the opiates and saying, oh, this is just so horrible, what an epidemic. But of course, the really true, horrible, severe, chronic underlying epidemic in the country is tobacco and alcohol. So we can't just forget about those, as much as we do like to talk about opiates. Second of all, just to suggest, this is just like big in the addiction medicine world right now, is your choice of words. So I would just encourage everybody here to use the words positive or negative, perhaps, instead of the words clean and dirty when referring to a urine sample, because that can be very stigmatizing. For women who are just had a baby, they feel vulnerable and they say, oh, your urine screen was dirty. It's just one more thing. So we're trying to get in the addiction medicine world, which is kind of, I'm finding, is sort of this psychiatric world. We're trying to get away from that term dirty. So I would encourage you to do that. But my main comment is that, of course, I am a Suboxone provider, and I'm gung-ho about buprenorphine in general. But I really am excited about treating newborns with buprenorphine in the future because of something you didn't mention, but the safety profile. If it's anything like adults, buprenorphine is so much safer than methadone or morphine. And I'm just really, really excited about these rural areas like northern Wisconsin, where babies could perhaps go home and be treated in local, community hospitals as opposed to being shipped to the bigger hospital in Duluth or wherever you live. And so these babies could be treated locally, a huge cost savings. The parents could stay with their babies, and they could be on buprenorphine, and they could perhaps even go home on buprenorphine. So I really am excited about that. I wonder if you had any comments about expanding your use of buprenorphine for treating babies.
I've been hearing a little bit about using buprenorphine for a little while, but recent New England Journal article is kind of the first good data that I've seen on how to do it. So I'm definitely excited to try it. But again, we would have to, we have a lot of steps before we can be ready to do that. And definitely before I think we would need more experience with it before we feel comfortable sending babies home on it. But but I'm definitely interested in kind of exploring that avenue of trying to use buprenorphine. And so I'll be watching for more data to come out to hopefully kind of tease out a little bit more dosing and tapering and that kind of thing. But yeah, so you know, with not having a commercial product, there's a little bit of work involved in getting ready to do that, but I'm interested.
I just wanted to mention that in moms who are on buprenorphine compared to methadone, the neonatal abstinence syndrome length of stay tends to be a little lower. Their symptoms seem to last not quite as long. So, you know, knowing that prenatally can be helpful.
Well, I want to thank my co-presenters for rounding out a great multidisciplinary approach to this very timely topic, and thanks audience for being here and being so engaged.